Hello and welcome. Today I will be demonstrating the assembly and use of a training model that we have developed to assist with training in post-placental and postpartum IUD insertions. First, let's review the model itself. The model consists of several components which, for now, must be obtained separately. First, we have the Simulades 180 obstetrical mannequin. This is a basic birthing model which is used to train students and residents in the birthing process. A number of other obstetrical models are available, but we have found that this one adapts most adequately to the other components of the model. It is also worth noting that traditional Zoe models, which are used for interval IUD insertion, may not be adequate or desirable for the postpartum or postplacental IUD insertion process. This is largely because the introitus on the Zoe model is too narrow and too limiting to adequately simulate the postpartum situation. And in addition, the uterus that is part of the Zoe model involves a cervix which is too narrow and too rigid, again, to adequately simulate a postpartum condition. To simulate the postpartum uterus, we have assembled a number of components which are commonly available from suppliers in the US or perhaps abroad. First, we have a built New York wine tote. This is originally developed to hold 2 wine bottles separated by a seam in the middle, each side holding a bottle of good wine. For our purposes, we remove the center seam, creating a single cavity which simulates the size and depth as well as the texture of a postpartum uterus. Next, we have a stuff sack with a soft lining which is again used to simulate the endometrial component of the postpartum uterus. This stuff sack is also available at camping stores, commonly through REI in the USA, but could also be assembled from local resources if a velour-like lining and a nylon exterior were available. One of the advantages of this type of stuff sack is that when inserted into the uterus, the collar can be folded backwards, and note that there is a cinch cord which can be used to create an artificially open or closed cervix and a cuff which also mimics the postpartum situation. Next, we have a commonly available tea towel or green operating room towel which we insert into the top of the stuff sack in order to give the uterus a little bit more heft and allow a crevice or two to allow the IUD being inserted during the simulation to be seated. It is helpful to have a safety pin to be able to attach this tea towel to the top of the uterine model. Finally, we have a neck pillow commonly used for long airplane trips, and many of our trainers have had to rely on these pillows not only for the training but for the airplane trip itself. You'll want to make sure that you use a Stanford official neck pillow. This pillow is then used to insert into the mannequin to create the impression of an anteverted postpartum uterus. In order to assemble these components, first one takes the wine tote, as previously described, with the center seam removed, and inserts the stuff sack into the cavity of the wine tote. Once this is done, one folds the collar of the stuff sack backwards to create a cervical os or a cervical cuff. And as previously described, one uses the drawstring to create a cervical os which can be widened or narrowed as the trainer desires. Having assembled the various components of the model, let me now demonstrate how to insert them into the obstetrical mannequin. First, the abdomen of the model can be removed and needs to be removed in order to first insert the pillow, which helps create an anteverted uterine attitude. Once the pillow is inserted into the cavity of the mannequin's abdomen, then one takes the assembled uterus and pushes it down into the pelvis such that when looking from the vaginal side, one can see the cervical os appearing in the vagina just as it would during a delivery. Then one places the abdomen back onto the model to simulate, again, an actual postpartum situation. And once this is all assembled, you will note that the uterine height comes just about to the umbilicus or just below to simulate a postpartum uterine size. That concludes the assembly of the obstetrical postpartum IUD insertion model. Thank you. Now, I will demonstrate the post-placental or postpartum IUD insertion procedure as simulated using the model that we have just assembled. Although the steps of this procedure are consistent across most organizations, we have used the steps as outlined in the U.S. aid-funded Acquire project and developed by Engender Health. Please refer to the Acquire project website for full training materials. Before proceeding further, it is understood that a few caveats must be recognized before actually inserting the device. Of course, at the time of the delivery, the general steps are baby out, oxytocin to prevent postpartum hemorrhage should be given then, the placenta is then delivered, there is obviously no postpartum hemorrhage apparent, and no second twin. It is at this point that the IUD insertion process can begin. A few caveats must be recognized, and you see them here on the screen in order to effectively and safely insert the IUD in this postpartum situation. It is assumed that before an insertion takes place, the provider will be familiar with the third stage of labor, with postpartum anatomy and physiology, and the ideal timing for postpartum IUD placement. In addition, the provider must assess that the patient is appropriate for postpartum IUD use, ensure that the patient has received appropriate counseling and has consented to the procedure, and follow local infection prevention protocols. The procedure I will be demonstrating is the forceps insertion version of the postpartum IUD insertion. Using a ring forceps, such as the one here, we believe is preferable to a manual insertion for two main reasons. One, we are concerned about infection prevention issues at the time of insertion. And two, we believe that pain and discomfort may be less for the woman when using a forceps as opposed to a manual insertion. In addition, some organizations advocate the use of a Kelly placental forceps for IUD insertion. We, however, feel that the standard ringed or sponge holding forceps is perfectly adequate for the purposes of postplacental or postpartum IUD insertion. Recent data indicate that when oxytocin is given and the uterus contracts rapidly after delivery, the uterine depth is sufficient to allow for the use of a standard ringed forceps, which is commonly available in obstetrical settings around the world. Let me review some of the other instruments that you will need to safely and effectively insert a postplacental IUD. Most of these instruments, in fact, all of them, should be available in any obstetrical suite worldwide. First, we will need 2 sets of ringed forceps as previously described. It is useful to have at least 1/2 of a standard speculum a SIM speculum will also suffice for this purpose, or one can use the forefingers of the non-dominant hand to depress the perineum during the procedure. Sterile gloves, although not pictured here but represented by these clean gloves, is required for the procedure, as well as swabs of some sort to clean the cervix and the perineum prior to the insertion procedure. In addition, you see a number of IUDs displayed here. Any of these IUDs can be used in the post-placental or postpartum situation, and some have various characteristics. For example, you will see here an IUD that is produced in Brazil, has the standard copper T 380 configuration, but has a much longer string than the copper T provided by Paragard, which is manufactured in the US. This longer string can be very advantageous in the post-placental setting, as the string may appear at the level of the cervical os after the procedure and does not indicate that the placement of the IUD is inadequate. Another version of an IUD that can be used is this IUD based on a variation of the multi-load IUD. This one, available in India and termed Freedom 5, is also capable of being used in the post-placental or postpartum situation and has an even longer string of about 20 centimeters, which definitely will protrude through the cervix at the end of a post-placental or postpartum procedure. The Mirena IUD, although not commonly available in developing countries, is widely available in Europe and the US, and this IUD, as shown here by this sample, has a much longer insertion device, and therefore when inserting the Mirena IUD, a forceps is not necessarily mandatory for insertion of this IUD. The strings are also much longer and will need to be cut at the end of the insertion procedure. First, the abdomen should be palpated to assess and verify the uterine height. This will assist the operator in knowing where the fundus is and assist the operator in achieving fundal insertion with the IUD. Next, the operator must insert sterile gloves, clean sterile gloves, on their hands to remove any of the contamination that may have been present as a result of the delivery. With sterile gloves now donned, a clean swab, cotton wool, or a sponge can be used with the combination of a disinfectant such as betadine to cleanse the perineum, removing any soiling that may have occurred during delivery. Next, the operator must use either the speculum or the forefingers of one hand to identify and locate the internal os of the cervix. If light is inadequate, a simple flashlight can sometimes be used, held by an assistant, to help the operator locate the lips of the cervical os, which can be visualized here, and grasped with a ring forceps such as we have described already. Once this has been accomplished, it is now time to prepare the IUD itself for insertion. Once the IUD has been removed from the package, it can be prepared for insertion by using the ring forceps and placing the ring forceps at an angle with respect to the T, such that the strings are moving away or guided away from the shaft of the forceps. This will help ensure that the strings do not get entangled with the forceps as the forceps is removed from the uterus. The IUD should be grasped right near the T-junction of the shaft and the arms of the IUD, and ratchets should not be closed on the instrument because closing the ratchets may damage the copper on the IUD. Once the IUD has been grasped in this fashion, the introitus is opened, more or less as such, the lips of the cervix identified, and the IUD inserted into the vagina and into the cervix. Once the internal os of the cervix has been broached, the forceps is dropped and the operator's hand moves to the abdomen to feel the IUD approaching the uterine fundus. Once that occurs, and for example, even now I can feel the IUD on the forceps at the uterine fundus, then the forceps are opened as wide as the operator can, moved laterally to the same side of the uterine cavity as the hand inserting the forceps, and the forceps removed, leaving the IUD at the fundus of the uterine cavity. Once this has been accomplished and the strings may or may not be visualized at the cervical os, the forceps holding on to the lip of the cervix can be removed. The patient, again, checked for any obstetrical issues, and that concludes the IUD post-placental insertion process. So in conclusion, postpartum IUD is a safe, effective method that offers integration of obstetrics and family planning, especially in settings where access to long-acting reversible contraceptives are difficult or challenging. Thank you very much.